Rami, talk to us about your experience with managing the toxicities associated with venetoclax.
Right, so that's something we are now doing on a daily basis. Actually, just like, because in our practice, a lot of the patients that we see are treated by our colleagues in the community, and they come back and forth. So we deal with this a lot. We've treated probably by this time more than 150 patients of studies with the combination. One thing first, like I tried to do some of what was done on the study. We don't de-escalate the dose anymore, like we don't admit the patients. But if patients' white blood cell count was high, we try to bring the count slower, below the 25,000 or 30 to start the treatment, put them on tumor lysis, prophylaxis, hydration, all that before starting the treatment. I think the key is, and this is a regimen that's been used by the community colleagues and can be done near home, with the caveat that we are so much used to use azacitidine alone in MDS and AML that we used to start the patient and say, you are going to see the response in 3-4 months, go, I'll see you back. You cannot do that with this. I think the dosing of the venetoclax is the tricky part, and you just have to find the sweet spot of the dose. So what we do is, like, we start patients on either the 400, but if they were on prophylactic antibiotics, we dose reduce accordingly, down sometimes to even 100. At the end of the first cycle, we repeat a bone marrow, and we assess if there is myelosuppression, hypocellular bone marrow. We hold both treatments, and we await some recovery. And then we may do a little bit dose modification, 3 weeks out of 4 weeks or 2 weeks. I think the key really is reassessing the disease early on and modifying the dose, because if not, you will see profound myelosuppression, febrile neutropenia, and infection. That's had been my approach.
The drug interaction problems are really, you've got to have some experience recognizing them. Again, we want to use mold-active azoles in our patients, but huge drug-drug interactions, you have to know to reduce that dose.
Yeah.
Quite dramatic.
And it's not just that, it's actually MDR inhibitors, carvedilol, very frequently prescribed to our older patients, will also raise levels.
And a lot of people don't know that about Coreg, but you had better watch out.
Yeah, you have to be careful with that. And so I would just add to this that even with cytoreduction to a white count that would have gotten them a patient on the study, I have seen tumor lysis syndrome, I've seen cytokine release syndrome with this very abruptly within the first day. And so if you're not set up like you probably are at Moffitt and MD Anderson to see these patients in clinic, check tumor lysis labs at the end of the day before they go home, if you're not set up to do that, I'd be very careful and admit them. Dan?
I completely agree. I mean, in fact, we continue to admit patients, high risk, low risk, regardless of counts. We continue to do the dose escalation. It's, at this point, it's probably out of habit. I mean, we've also treated close to 175 patients, and we, do things still the same way we've become accustomed to doing them from what we learned in the clinical trial. I don't necessarily think that the way we do it is, the only way or the right way, but it's the way that works for us. And, it's long been a concern of mine that was the tumor lysis incidence so low because of the biology of the disease. I believe that that is true, that this is not CLL, but also was it as low as it was because of the mitigation techniques. And so I'm hesitant to abandon those until at least I have more experience, or similar to the rules for CLL with venetoclax, someone can tell me, look, these are the high-risk patients, this is how you handle them, these are the lower-risk patients. So until that comes out, I'm just more comfortable keeping them inpatient and being really conservative, but I don't think that that's necessarily the right thing.
Yeah, I think this is a very important point. I think the key though is kind of doing an end of cycle 1 marrow, like an early evaluation. I think that of all of this in the community, I think if we had to give a message, I think that's the one thing. They do not do continuous HMA ven 2-3 cycles until neutropenia.
I've had patients spend an entire summer without a neutrophil, basically.
Right.
When they didn't need to.
Yeah, right. No, I think early bone marrow and novel, the other part of that that Rami got to is take breaks. When patients achieve remission, which most of them do, they need breaks between cycles.
Yeah, so this is not HMA alone. I mean,
right.
I think that's the whole point.